Bismillahirrahmanirrahim. Welcome to our today's session. Our today's session will be about history taking in ophthalmology. History taking it is the base for every field in medicine, especially in ophthalmology. The history should allow for the recording of important information that could affect the patient diagnosis and treatment. In every history, we have 5 goals. Number 1, identify the patient. Number 2, identify other practitioners who have cared for the patient previously or may care for the patient in the future. Number 3, obtain a preliminary diagnosis, the likely diagnosis, or at least a reasonable differential diagnosis we have to make. Number 4, select therapy, knowing and recording treatment that have already been tried and whether or not. Or number 5, consider socio-economic and medical legal factors, and we will know how the patient can afford our treatment or not. So as history taking is an art that must be learned by each ophthalmologist with conscious effort. You have to first putting the patient such as an ease to communicate freely with trust with you, and also if you are taking the history, inquiry of these questions need a huge knowledge and an art of communications. Because you have to taking care of patient age, because different kind of patient you will present in your OPD. Children, teens, male, females, elder patients, and also the patient gender. You have to be careful regarding that. Custom, culture, language, socioeconomic status. Because sometimes you will find in your OPD a patient with a different socioeconomical status. He will be very elite class patient, or sometimes you will find a patient which will be from very far periphery. So according to that patient, you have to change your terminology and the way of asking the questions. If you are taking a history, so the good history should conclude with 3 differential diagnoses. And also you have to further, if you have a 3 differential diagnosis, for diagnosis you have to do your examination and investigation, and you will reach your diagnosis. So this will be a very lengthy video, so I hope you have to be patient, because this is a base for ophthalmology, and also other fields can also use this video as a guide. And you have to first watch this video, and we will come inshallah in the next session on how to apply this knowledge in practice. This is our OPD, and we are doing here practice. So now we are coming to our main topics. Number 1 is biodata. Biodata means that you have to ask the question name, father name. If the patient is female or married, you have to ask the husband name. Sometimes we have in our OT list the same name patients. They have the same name. We are differentiating them on the father name or on the husband name. And nowadays the biodata that are entry on the computer slip already, they are inserted in that. So but in sometimes you have to be these history may be handwritten or on blank paper, and also sometimes you have to take the history and then enter on a computerized database system. So in the biodata, number one, you have to ask name, father name or husband name. Age is important because there are certain diseases that are more common in children, in teens, or in adult, or on the old age. In the children we have congenital cataracts, in teens we have VKC and also keratoconus. In adult we have more trauma, and old age we have more cataract. So we can differentiate between just by the age between different disease. And also gender, you have to ask some diseases are more common in male, and some are more common in females. And during taking history, don't use the word sex, use the word gender. It is good. And also address, importance of address, because some disease are common in certain location. TB is more endemic in our area, in South Asia, like Pakistan, Afghanistan, in India, Bangladesh. So we have to ask regarding address. And also nowadays it's important, according to current requirement, ID card and also contact number, that in the future we have to contact our patient. And also occupation, we have to ask from the patient what he is doing, because we know just by asking these questions what he is doing, we know the demand of vision. For example, a driver, he need more vision. A welder, he is more exposed to trauma. And a teacher who need more near vision. And a farmer, he don't need near vision, and if he have a gross vision, for example 636, he will be comfortable. But a patient like a teacher, who is studying every day, he need a high vision demand. So by asking these questions, we can differentiate, and we can identify our patient. Number two is presenting complaint or chief complaint. What is presenting complaint or chief complaint? It is a recent happening that has brought him to take consultation. What happening to the patient, and what happened recently with his or her to brought him for consultation to our OPD. So how we can it's also an answer of how can I help you. In ophthalmology, chief complaint, yes, CC. Some practitioner, they are writing CC as a abbreviation, it means chief complaint, or sometimes they are writing PC, presenting complaint, they are the same. In ophthalmology, chief complaint that are straightforward, like decreased vision. Patient will say to you, I have decreased vision. Then you will go and check it, the patient will have decreased vision. The patient will say to you, I have a pain. And the patient will say to you, I have watering. He will say to, I have a drooping lid, deviation of the eye or strabismus, I have a redness, I have a mass, I have a bulging, I have a discharge. Discharge will be different kind of discharge. Then you can ask in details, that is a watery discharge, mucus discharge, mucopurulent discharge, and purulent discharge. So you have to differentiate according to the patient. And sometimes patient will say, I have double vision. So for every these of patient, so this is a whole ophthalmology which I'm explaining for you. So the patient will come, I have decreased vision. So according to that, you have to ask the questions. So this is dopara. Dopara, it is the explanation of the chief complaint, or it is also called history of presenting complaint. So when you are taking the history in chief, when you are asking the question in chief complaint, you have to ask the patient onwards. And also you have to not jump prematurely to diagnosis. So then you have to ask from the patient if the patient has decreased vision. So you have to ask the duration, D for duration, O for onset, P for progression, A for aggravation, R for relieving factor, and A for associated other symptoms. So you have to ask these all questions from the patient in the history of presenting complaint or history of chief complaint. And you can use in the history of presenting complaint or chief complaint a medical word also, and it should be in chronological sequence. Number 3 is the past ocular history. This is the most important part in ophthalmology, and you have to take this in very details. So this is a very good mnemonic in every ophthalmologist or ophthalmology resident that he should remember as a mnemonic. GST-MEL. GST-MEL. It stands for example, you have to ask from the patient, you have used previously glasses or not? If he has used the glasses, then you can ask the questions. The glasses was in plus number or in minus number. Or you can ask the patient, it was for far vision or for near vision, because youngsters, they have more myopia, so they are using that for far vision. And patient who are elder, 40 plus, they have decreased vision for near, so they are using for presbyopia. And also on S, it means surgery. The patient previously has done any kind of surgery, like there are multiple kind of ocular surgery, like cataract surgery, glaucoma surgery, strabismus surgery, and RD surgery. So you have to differentiate. For example, you have to ask the patient before for what purpose you have done the surgery. If the patient is saying that I have decreased vision, so that was cataract surgery. If the patient is saying that there was pain in my eye, so and raised IOP, that was for glaucoma surgery. If the patient is saying that my eye was deviated, that was strabismus surgery. And if the patient is saying that there was already like sudden painless loss of vision, so that is RD surgery. And also you have to ask from the patient trauma. There was any kind of trauma to the eye, for example blunt trauma, for example with a fist, penetrating trauma with glass or any kind of wood, and perforating trauma with any kind of very fast bullet. We have to differentiate between penetrating trauma and perforating trauma. Penetrating trauma means that there is just eye or eyeball is penetrated, and the material which has been penetrated, that is in the eye. Or perforating means that the patient, for example, there is entry point and exit point. Their entry point is 12 o'clock and exit point is at the equator, and there are two holes in the eye. That is a perforating trauma, which is with a fast bullet-like material that can occur. And also you have to ask from the patient that he has used any kind of medication. Currently he is using any kind of medication, especially drops, like he is using any kind of prednisolone, lubricant, which is for dry eye. And also he is using any kind of medication for the VKC, which is more common in the youngster. And also you have to ask from the patient injection. He is using any kind of injection, like anti-VEGF injection we are using in the patient who has diabetes mellitus, posterior subtenon injection, intravitreal antibiotic in the case of endophthalmitis. And at the end we have to ask from the patient that you have done any kind of laser. We have different kind of laser in ophthalmology, like Nd:YAG laser, which we are using for the posterior capsular opacity. We have green laser, which we are using for diabetic retinopathy, for PRP, and selective laser trabeculoplasty we are using for the glaucoma, and LASIK, which is a kind of laser we are using for myopia treatment. So the remaining part of the ophthalmological history, that is very simple, which is past medical history. We have to ask from the patient that he is diabetic or not, because if the patient is diabetic, there will be complication of diabetes like diabetic macular edema or diabetic retinopathy. We can our diagnosis can be narrow. If we have to ask from the patient hypertension, he has hypertension or not, because hypertension can lead to central retinal vein occlusion, branch retinal vein occlusion, and hypertensive retinopathy is if we have to ask from the patient ischemic heart disease, asthma, and rheumatoid arthritis. Even these questions, if we are asking from the patients, so this question has a rationale. Why we are asking from the patient asthma? Because we are advising for the patient medicine like beta blockers, timolol. We have to not advising the patient of asthma. Why we are asking about rheumatoid arthritis? If the patient has rheumatoid arthritis, he will use for a long time. He has used for a long time steroid, and if the patient is for a long time he is using steroid, there will be that steroid can lead to cataract. So we are asking these questions for that purpose. And also we have to ask the family history. What we have to ask in the family history, if there is any kind of any patient in his family, like siblings, his spouses, has any kind of glaucoma, congenital cataract. Today we had a patient who had when there was siblings, both had cataract, both one age was 7 years, another was 8 years. That was mature cataract, and so that was a congenital cataract. And RP, retinitis pigmentosa, we have to ask myopia, if the patient has myopia or not in their family. Strabismus, in some families strabismus is familial. In our one of our relative, they have their brother and sister, sibling, they all have the strabismus. So these family history we have to ask from the patient. And also personal history like smoking, alcohol, tobacco, we have to ask from the patients. One of the patient I knew, and I know that he had a pale optic disc, and he said that I have someone given to me some things. One of my friend has given some things to me, but after a lot of examination investigation, he was not giving us a good history. But at the end, he said, I have taken alcoholic beverages. So we have to ask personal history. And also we have to ask the sexual history. For example, the patient is married or not. Syphilis we have to ask, because we have due to syphilis, we have syphilitic retinitis. We have to ask about the AIDS. If the patient has AIDS, so there will be cytomegalovirus retinitis. Our differential, we can make in differential that also. And in sexually transmitted disease, we have to ask from the patient. And also in the drug history, we have to ask if he is using any kind of systemic medicine like steroid, immunosuppressive medicines, insulin, and also if the patient has inflammatory bowel syndrome, he is using any kind of medicine or not. And also we have to ask about the drug allergy like dorzolamide, which is a sulfamethoxazole, that is derivative of that. We have to not advise if the patient has already allergy to that. And this is our OPD slip. In every institution, according to their need, they are making their own OPD slip. So you can find here at the superior left side. First of all, we have taken the biodata, which is the name, father name, ID number, and also address, occupation. Then we are asking chief complaint. The chief complaint of the patient is watering since 5 years. Then we are asking G stimul, which is the past ocular history. We have asked from that, and also at the end, at the lower end of left side, you can see the past medical history, which is diabetes, hypertension, ischemic heart disease, asthma, and allergy. Then we have done the ocular examinations, which is the vision, unaided vision 624, and pinhole it improved with 612. Then best spectacle corrected visual acuity we have to write in the superior side. Then extraocular movement, then applanation tonometry, then Marcus gun and or RAPD, that is negative, and macula and disc. And according to that, we have advised our investigation, and then we have written the plan. So these are even institution, they have their own requirements, and according to what I have previously explained, that was frame for all ophthalmology. So this is our frame. So you have to, when you are taking the history, you have to be careful, and this is the whole basement or foundation for ophthalmology. And if you are taking a good history, so you can pass your long case very easily, because it count in your part 2 also. Thank you from your time and attention.